All right, good afternoon, everyone. Well, the topic of today's lecture is all about peripheral vascular disease. So we'll talk a little bit about peripheral vascular disease and then a lot about how to image peripheral vascular disease. So, I was planning today to have one of the vascular surgeons with us and to present, their, aspects of management from their side. But unfortunately, he was unable to make it today. So I'm going to get going with some brief introductory slides. So peripheral arterial disease is very common. It affects almost over 8 million Americans. And if you look at nationwide, worldwide statistics, almost 202 million people worldwide. So this is a disease that we are readily going to see. It's an important marker for elevated risk of adverse cardiac events. We know those patients who have peripheral arterial disease are at increased risk of heart disease, myocardial infarction, stroke, and of course, cardiac death. But in addition to that, peripheral arterial disease also affects quality of life for patients by limiting their functional capacity, both with the onset of symptoms with claudication and also major adverse limb events, such as critical limb ischemia that can lead to amputations and things like that. So this is a common disease that we will see that has major effects for the cardiovascular system. Now, if we look at some, epidemiological studies, you can see from this slide that common risk factors predispose you to having peripheral arterial disease. And the two biggest risk factors for peripheral arterial disease are smoking and diabetes. You can see from these epidemiological studies that can increase your risk almost fourfold compared to somebody who does not smoke or does not have diabetes. Similarly, if you look at patients with peripheral arterial disease and you stratify them by their age, you can see as we age, the incidence and the prevalence of peripheral arterial disease steadily increases to where those patients with who are greater than 75 have almost more than 20% chance of having the disease. As a result, the guidelines have published those patients who are increased risk for peripheral arterial disease that we should be screening them. And these are patient populations anybody who's more than 65 years of age, anybody whose age between the ages of 50 and 64 who has risk factors of atherosclerosis, and that of course includes diabetes, smoking, dyslipidemia, hypertension, or a family history of peripheral arterial disease. People even younger than that, those less than 50-year-olds who have diabetes and maybe one additional risk factor, let's say dyslipidemia or hypertension, that would count. And so even those patients who are less than 50, if they're diabetic, consider screening for peripheral arterial disease. And then finally, obviously, if somebody has any vascular disease in any organ bed, for example, if you find carotid disease or subclavian disease, or if they have renal artery stenosis or have a AAA, these are all patients. If you have disease in one vascular bed, you can definitely have it in others. So these would be another patient population who would be at increased risk for PAD, who you should consider screening for, as recommended by the guidelines. Now, in general, in your as busy cardiologists, we see patients, frequent, both in the inpatient and outpatient setting. In the outpatient setting, the most common manifestations of peripheral arterial disease, most patients will be asymptomatic from it. The other way they're going to present to you in clinic is obviously if they're having claudication, and we'll talk a lot about that. There are other presentations of PAD. Those are in the inpatient setting, and we'll get to that. But the most common is, if you don't screen for your patients, a lot of times these patients are going to be asymptomatic. They'll often modify the level of exertion that they do in order to, not have lower extremity symptoms. Or simply these patients may come into you telling you that they have some lower extremity symptoms. So one of the important things I think we should define is what is claudication, you know. Any of y'all want to have a good example of a patient you've seen who has symptoms, and how did they describe it to you? Please.
Whenever they walk a certain distance, their legs would tighten up, and the legs would tighten up, and then they said usually when they would rest, the tightness would go away.
Yeah, it sounds just like angina, right? But it's of the lower extremities, and you're absolutely right. So the classic symptoms of claudication are, and then they'll present to you many ways, but it'll either be some fatigue, discomfort, cramping, you know, in the muscles of the lower extremities. And that also has a definition. What muscles are we talking about? This is going to be the buttocks, the thighs, the calves. These are very common areas. They're brought on by exertion. They usually occur at a very consistent level of exertion. And just like angina, they quickly get relieved with any sort of rest. And this is important because, you know, patients have a whole host of other conditions that can give them lower extremity symptoms. And we call that, you know, pseudoclaudication, you know, things that, you know, have symptoms of the lower extremities but may not necessarily be of vascular origin. Those are often described as a tingling, the burnings, the numbness. You know, they may not necessarily occur with the exertion. They're more prone, you know, to, you know, they tend to, if they do occur with exertion, it won't be after a fixed amount. It's very variable. It takes greater amount of time for the pain to go away than a very consistent time to pain relief when exertion has stopped. So all of, you know, this, it's very important to kind of, when you hear a patient's story, try to in your mind figure out, is this a vascular origin or is this something else? And the guidelines also show you, you know, when it's a non-vascular origin, these pseudoclaudic kind of patients, there's a whole variety of different conditions. And I think the most common ones that I've seen in my practice are at least the people who have a lot of venous insufficiency, who have spinal stenosis, or have some nerve root compression. Those are often the ones that they'll be telling you. But again, in general, those are patients, you know, who are going to have a lot of discomfort with pain upon standing, who are going to have a lot of the tingling, burning, numbness kind of discomfort. So important to know, you know, what that definition is. The other group of patients that, you know, when you're rounding in the in-hospital, you know, more than likely those patients are going to present to you with peripheral arterial disease in a completely different manner. Instead of having claudication now, they're rather going to present with, you know, symptoms of critical limb ischemia or acute limb ischemia, and these are all manifestations of a much more advanced disease. And I'll only make mention here for acute limb ischemia, you know, it's kind of like a heart attack, you know, we should be aware of it. And this is really where, you know, you're going to be getting in touch with your, you know, your interventionalist, your vascular surgeon. So these are patients with acute limb ischemia who present with the 5 Ps, you know, the pain, the pulselessness, the pallor, the paresthesias, paralysis. These are probably readily tested board questions, or at least were on, you know, the steps that you have already taken. So the guidelines recommend that in those patients who we've mentioned who are at risk for peripheral arterial disease, you know, all the patients who have risk factors for atherosclerosis, the elderly, the diabetics, the smokers, that these are class 1 indications to perform a comprehensive history. And it goes, and the history is exactly what we talked about, just, you know, eliciting from them, you know, signs and symptoms for claudication, signs and symptoms of, you know, pseudoclaudication symptoms, finding how much they can walk, you know, finding out when their pain is, how long the pain lasts, what relieves it, the intensity and the type of pain they have. Very important to elicit this. And then, of course, to perform a physical exam. And what are we looking for in the physical exam? This is where, you'll have, where we'll have to examine our patients. We can look at their feet, their legs. Do they have hair present? Do they not have hair present? Do I feel pulses? Do I, where are those pulses? Listening for bruits, looking for wounds, looking for ulcerations in the skin, and then some very advanced findings that are demonstrated here, which is the elevation pallor and the dependent rubor. So, so very important that in patients with, of course, with peripheral arterial disease, that we do these checkups, and even also recommended is, in our guidelines and from medicine and everything, diabetics especially should have regular feet exams, right? So what's the next step? We've done our history, we've done our physical exam, and the science, we have features that are in one or the other that are suggestive of peripheral arterial disease. The very next step is to perform an ABI. So this is a very simple test, and has anybody been to the vascular lab, seen how it's done? It's often done in doctors' offices, although we're not necessarily doing it, I believe, in our clinic, but this is, when you all go out in private practice, this is a very simple procedure to do. And it basically involves, inflating your blood pressure cuff across the brachial artery, and with a Doppler that will amplify, what you hear, seeing, what the blood pressure is in the brachial artery, as well as the vessels in the ankle, so the dorsalis pedis and the posterior tibial artery. So this test is markedly as simple as it is has a very, very high diagnostic accuracy, as we will soon talk about. And the guidelines say that, along with the ABI, you may or may not do segmental pressures. That's a little bit more involved. You put a series of pressure cuffs all along from the patient's hip all the way down to their ankles, and you're inferring where the disease is based on where you see a 20 millimeter decrease in lower extremity pressures. So points I wanted to make here is, I think, what should you know about the ABI? Number one, what you should know is that anything less than 0.9 is abnormal and is very specific for the disease. So you can see here from studies that for at least detecting a stenosis greater than 50% by invasive angiography, an ABI less than 0.9 has a specificity of 96%. Other things to know is that, obviously 1 is normal. So anything between 0.9 and 1 is what they consider borderline. And we'll talk a little bit about what we do with, that number. Then you have the very severe disease, which is less than 0.4. Between 0.4 and 0.9 is considered mild to moderate disease. And then every now and then your ankle vessels may actually have higher pressures than your brachial arteries. And these are often due because these vessels are heavily calcified and therefore are non-compressible. And as you know, you frequently see these in patients who are diabetics, your elderly, your renal failure patients. And those patients also then, the ABI in that particular group, the way it's done is a little bit non-diagnostic, and you need some further testing to help figure out whether they have obstructive peripheral arterial disease. If we look at the picture to the right, I put that up there because it's important to know how an ABI is done. So anybody here pretty knowledgeable about it and can walk us through, or I can help out a little bit. Any takers? All right, so first thing is you want to get measurements of blood pressure in both arms. There's a reason for both arms. Number one, it will help you diagnose subclavian artery stenosis, which can be very important. So obviously the patient's true blood pressure is the blood pressure that's higher. But the other reason is part of the equation here is to use the higher of the right ankle pressures, be the posterior tibialis or the dorsalis pedis, divided by the higher arm pressure, whether it's the right or left arm. So here in this particular case, so let's say if we focus on the right side, right arm pressure was 120, left arm pressure was 100. They measured the pressure in the posterior tibia on the right at 68, and the dorsalis pedis was measured at 64. So the ABI for the right side in this particular case would be the higher of the ankle pressures. So here you would take the 68, and you would divide it by the higher of the blood pressures. And that would be the 120, and you'd get 0.57. As opposed to the left side, here you can see the blood pressure in the ankle here was 136. The higher of the blood pressure divided by the highest blood pressure in the arms, which was 120, and you get a number of 1.13. So, and then, so important to know, I think, is that, it's not simply comparing just the right side. You're really using the higher blood pressure in either arm as your denominator, and the numerator then in your ankle is, using the highest number of the AT or the PT. Okay, so is that clear? Okay, great. So we have done, we had a patient, he had
Faisal, just one comment to that. Obviously, the one risk you have would be if somebody's got kind of bilateral upper disease, like bilateral subclavian disease, then the pressures can be low, so it can give you false negative ABIs. So I think just something to be aware of is a really bad vascular path. So at the end of the day, always go with the clinical judgment as well. Right?
Yeah. Yeah, you got to examine. You definitely have to examine your patient, and history is very important as well. So, we've diagnosed, we've determined an at-risk population based on epidemiological studies. Diabetics, smokers, the elderly. We've just talked to them. They gave us a concerning history. We examined them. We may not have measured pulses. Maybe we heard some bruits. We did an ABI, and in this particular pathway, if you look at the pathway recommended in this guideline document, you can see if your patient has an abnormal ABI, you have made the diagnosis of peripheral arterial disease, and the next question is, how do you manage and treat this patient? And very similar to what you see in the coronary space, the treatment is goal-directed medical therapy first. We'll talk a little bit about that, although that's not the main focus of my talk today. But you want to be very aggressive with goal-directed medical therapy. And only when that fails and your patient still has, is functionally limited by their peripheral arterial disease, then do you go on to considerations of revascularization. And of course, these are your claudicants, these are your asymptomatic patients. This is not necessarily your acute and chronic limb ischemia patients. So what about those patients who, may not necessarily always have ABIs less than 0.9, right? You may find those patients who we had said who have ABIs greater than 1.4. Those are those patients who have those calcified vessels who are non-compressible. And in this particular case, you'll see something here. What the next step that's recommended is something called a toe brachial index. And we'll go over that in the next few slides. But the main things are just to remember, if you have a non-compressible vessel, the lab will automatically go on and do a toe brachial index. And if your reading there is less than 0.7, again, this is a patient who has peripheral arterial disease, and you're back down to the same pathway, GDMT, before you consider revascularization. What about those patients who are in that borderline ABI numbers, between the 0.9 and the 1? What about those patients? Well, those patients, you may be actually able to induce, for lack of a better word, and further risk stratify these patients by doing an exercise ABI. And the idea is that by exercising these patients and then performing an ABI, if you will see that in those patients who have true obstructive peripheral arterial disease, their ABI numbers will now fall below 0.9 with exercise, and then now you're back down to the original pathway again that we spoke about. So whereas those patients who maintain their ABIs greater than 0.9, it is unlikely then that their symptoms are from peripheral arterial disease, and then you're going down that looking for those pseudoclaudicant kind of symptoms. So what is this toe brachial index? So this is kind of a stylized picture. You know, you're actually measuring, you know, blood pressures in the toe, you know, I believe it's calculated exactly the same way. You know, you know, by dividing the toe pressure by the higher of the two brachial indexes. Again, the number here is 0.7, and if it's more than 0.7, it's diagnostic for lower extremity PAD. Obstructive lower extremity PAD. And again, these are for patients who have the non-compressible vessels, so who have the resting ABIs greater than 1.4. The exercise ABIs are those for, again, those borderline patients. Now, how does exercise help you? Well, if you have, it helps you in two ways. Number one, just like it does in the cardiac space, when we watch somebody exercise, we learn a lot about them. So, you know, just simply watching them exercise, seeing when their symptoms occur, you know, seeing their functional capacity, all of that is very helpful to you to make a diagnosis. But then also, after exercise, ABIs are measured. If they now fall, if the ABI falls to less than 0.9, that's a patient with obstructive PAD. All right, so we have now made the diagnosis of PAD in our patients using a combination of these tests, possibly. And, you know, what are the recommendations for goal-directed medical therapy? Really, to be honest with you, no surprise to the cardiologists in the room that your class 1 recommendations are, you know, antiplatelet therapy with aspirin alone or clopidogrel alone. For statin therapy, again, treatment of statin is recommended. You know, I think all of us would agree that, you know, 2/3 of patients with PAD have CAD. Would probably be aggressive using high-intensity statins and lower thresholds for LDL. Control their blood pressure, you know, common sense stuff that everybody's used to. I think in the PAD space as well, big emphasis on smoking cessation. You know, this is a disease very closely tied to, you know, their symptoms are tied to smoking. So the quicker you can get them to smoke, the more chances you will relieve them of symptoms and save them from major adverse limb events. So, you know, get them on all these drugs that we have available to us. You know, Dr. Satish is an expert. You know, refer to her, she will help you out. Get them to a smoking cessation program if your institution has one. Big emphasis on this. If you're diabetic, obviously work with your endocrinologist, get the diabetes under control. What about drugs? You know, cilostazol, pentoxifylline, you know, what is recommended now? Really the only drug that's recommended to improve your walking distance is cilostazol. So I think that's an important drug. You know, the boards may try to trip you up with pentoxifylline, but remember, it's only cilostazol. They made mention of influenza vaccine. Maybe one of y'all know why, but I imagine, you know, just prevent inflammation and plaque rupture, I imagine. And then very important in the PAD space as well as exercise structured program. We know that patients who are claudicants, who are on regular exercise programs, they can actually increase the distance that they walk before they develop symptoms. And a lot of this may be due to ischemic preconditioning and things like that. So very important for them to early on be part of an exercise, structured exercise program, you know, where you, or even if you not one available to you, where you tell them to walk to the intensity of pain, maintain that for a little bit, slow down, and, you know, keep on making that effort. And over time, they'll see that they're able to walk further and longer. If none of this works and your patients continue to have debilitating functional lifestyle limiting symptoms, then it is recommended that you can consider revascularization. Now, this is where the next portion of the talk comes in, is, you know, when our interventionalists like to do procedures, they often like to know, you know, what the anatomy they're dealing with. And as you know, in the peripheral disease space, you know, you can have you can have you have many different vessels in the lower extremities. They can have all sorts of different types of, combinations of blockages, and it's very helpful to them to know beforehand, what the anatomy looks like, so they can plan their procedure, be it endovascular or surgical, a priori. So the guidelines actually recommend in that case that any of the 4 imaging modalities that I've highlighted here, be it digital subtraction angiography, be it ultrasound, CTA, or MRI, these are all excellent tests where you can accurately evaluate the lower extremities, and for 2 reasons. Number one, if you're still uncertain about the diagnosis, or a patient, you have some mixed results, you can very confidently now identify the disease and make a diagnosis. Or number 2, if you are planning revascularization, finding out where the disease is, how bad it is, seeing the lay of the land, and helping you plan whatever procedure you're planning to do. So the next really half of my talk really is discussing some of these other imaging modalities. This is an imaging conference, and displaying some of the strengths and weaknesses of each of these techniques. So the gold standard is, no doubt, is digital subtraction angiography. And again, this is when revascularization is planned. Spatial resolution is the highest that we have. We're all used to seeing these images. We're all used to making stenosis determination and performing an intervention based on these images. However, this technique does have its limitations. A lot of this may be review from other conferences we've also had. You know that this is a couple of things. This is simply a 2D image. So you're just basically seeing a luminogram. You can really underestimate stenoses if you have eccentric lesions, and in that particular plane, you may not necessarily see the eccentric stenosis. You really have no idea what the vessel wall looks like or how much atheroma is there. And then let's not forget, these are invasive procedures. So, you're going to be sticking somebody in the groin. You're going to be taking the risk of an arteriotomy and the risk of bleeding. You're going to be giving iodinated contrast, which your study will employ. And then, of course, this is also a pretty big radiation dose as well. So it is the gold standard, but there are some limitations involved that we have to be aware of. What about ultrasound? Well, ultrasound, has the advantage. It's completely radiation-free. It's available everywhere. So, and it actually is very specific for, when you identify high velocities, it's very specific for a significant stenosis. The problem with ultrasound is that sometimes body habitus does not let you see the entire arterial bed. So if your patient is obese, you may not be able to accurately assess the adductor canal or the aorta-iliac region, just because you can't visualize those vessels because of the amount of adipose tissue or because of the amount of loops of bowel that may be present. Similarly, the infrapopliteal vessels, they are small and they can be really technically challenging, and they can be difficult by ultrasound. So, and then of course with ultrasound, if you have a lot of calcium present, all those ultrasound beams are going to bounce right back, and that can create shadowing behind the vessel, and can also limit your interpretation there. So it can really be, its major disadvantages are then, of course, that you're not really seeing, you may not necessarily see the entire arterial vasculature to help you make the informed decisions that you need to be able to make. And calcium can also be a problem. What about these guys, CT and MR? I'm a fan of them, so I'm biased, but I'm trying my best to give you a very, balanced approach to all of this. But these techniques, as you've come to know, these are unlike 2D angiography. This is a 3D technique. It has very high spatial resolution. Maybe not as high as what we're seeing in the cath lab, but very, at least with CT, very comparable. large field of view, so we're able to, see, accompanying organs and things like that. We have a lot of tools and tricks to help us to visualize stenoses, to be able to, accurately make a correct diagnosis. And you'll see in some of the data I'm about to show you that it has exactly, as good diagnostic accuracy as the invasive procedures. And these tools can be very helpful to our interventionalists in planning their procedures because they see the entire lay of the land. These are just some of the tools that we use every day in both the labs, be it CT or MR, in order to help us visualize these vessels. We have, just like in the cath lab, we can create these MIP-like images, which are just luminograms, or we can create more lay of the lands, like these MPRs, where we can actually see the whole a vessel and the vessel wall. We can see the amount of atherosclerotic plaque burden there is, what type of plaque it is. We can see the calcium, especially with CT. We can see the bony tissues and landmarks to help us localize where particular disease or stenosis may be. We can see contralateral vessels. So, and if I didn't mention it already, to be able to see the vessel and the plaque that's involved. So, all of these tools are available, as to help us in order to provide this information to our interventionalists. So I think that leaves you considering, that if you were going to begin, if you had a patient now who you've screened and you've diagnosed with ABIs, and you're left, you've tried GDMT, but they're ready for, they're functionally limited and they're ready for something to be done, and you're considering revascularization, if you're not directly going to the cath lab, maybe for, patient-specific factors, how do you choose between some of these tests? And that's really the third part of where this talk is going to go. So I think things that you should consider when you're considering between CT and MR are, what is the diagnostic accuracy? Are these tests any good compared to the gold standard? What is the strength and limitation of each technique? And this will really come into, what are your patient's individual characteristics that you have to take into account. So you want to choose the best test for your patient. Not every test is best for everyone. Some patients may have more calcium and maybe an MRI is better. Those patients who have less calcium, CT may be better. So you have to consider what the limitations and strength of each modality, consider the patient's characteristics, and consider whatever risks inherently the test has itself. And so we'll discuss a little bit about that. So when it comes to diagnostic accuracy, no matter what arterial bed you look at, with CT, if you just look at the red boxes, you can see the sensitivity specificity. These are highly accurate tests, for diagnosing disease. And remember, these are all compared to invasive angiography. MRI is not to be left behind. Also, a fair contrast enhanced MRI, very, very accurate when it comes to diagnosing disease. So I don't think you have to worry when it comes to diagnostic accuracy, which of these two modalities you choose. Just for completion's sake, if you look in other arterial beds, whether it's the carotids, here the study is showing, MRI, just like CT, is extremely accurate. MRI, you have the benefit as opposed to, an invasive procedure where you're threading catheters to these, to the arch vessels, that you really have zero risk of stroke with it. If you're looking at the renal arteries, very, very high accuracy. And then finally, what about bypass grafts? These in general, these imaging techniques, because these bypass grafts are big, we're not going to have any trouble with our spatial resolution identifying blockages and being very accurate with it. And there was actually, believe it or not, a randomized trial that looked at MRI and CT. They took 514 patients, I think, PAD patients, and they randomized them to a strategy of getting anatomical information with MR or CT, or anatomical information simply with ultrasound. And just, just the highlights of this study, they found that those patients who were in the arm of MR and CT, the proceduralists had higher confidence in making therapeutic decisions. They ordered less tests, and in the long run, this proved to show to be cost savings as well. So you really do get a lot of very valuable information that can save costs and help your proceduralist when you're using some of these 3D techniques. All right, so other things that we should consider other than diagnostic accuracy, we'll just jump right into. CT, what are some of its strengths, right? CT is one, there's scanners in every hospital, so they're readily available. It's a very rapid technique. Those of y'all have seen, especially with the newer scanners, patient gets contrast and boom, you're following the bolus of contrast through the arterial bed and you're done. It's fast. It can be done in less than 5 minutes where, Dr. Shah, you want to tell us how much an MRI takes? Okay. Okay. So, and then, of course, other advantages we already spoke about, the large field of view, but most importantly, very high spatial resolution. If the cath lab is 0.2, we're getting isotropic voxels at 0.5. So you're seeing things, you're seeing things accurately. Where can you maybe not see things? Okay, very, very small vessels, distal arteries, but I'll also argue with you that maybe those aren't vessels you're going to be intervening with anyways, so if you can't see them. Big advantage for CTA when it comes to peripheral stents. Most of the stents in the peripheral vasculature are big, definitely bigger than 3.5 millimeters that we're using in the coronaries. So you're not going to have any trouble evaluating stents, evaluating for in-stent restenosis. This is just some data showing you, the diagnostic accuracy using CT when it comes to identifying disease within peripheral stents, and it's very, very, very high. Smaller stents, sure, just like the coronary space, if you have a metallic structure, you may have beam hardening artifacts that could limit your ability to interpret. But I will say, of all the peripheral stents that I've seen, whether it's in the carotid sphere or the aorta iliacs, or in the, we really have no issue with a stent interpretation or beam hardening artifacts in those vessels, or even the renal arteries. Where does CT have problems? Well, CT, just like in the coronary space, has problems with a lot of calcium. And the calcium, it turns out, is a blessing in one end and also a nuisance at the other end. We'll start off with the blessing. Blessing, it helps the interventionalist. He knows where the calcium is, and it helps him, maybe it's important for his stents and, being able, once they deploy them, to being well anchored and things like that. And so it can be helpful in that regard. But when it comes to stenosis assessment, it's a serious nuisance, because the more calcium you have, the more blooming you can have. And this blooming leads to an overestimation of stenoses and therefore false positive results. And as we know in our patient population, who are often elderly, diabetic, renal patients, these are the people who tend, obviously, to have peripheral arterial disease, but then also to calcify their vessels. And so, it is not unheard of, or you may have very well seen reports where we have mentioned that, in some segment of the arterial circulation, dense calcium was seen. We really couldn't see into the lumen. We have no idea what's going on with the degree of stenosis that's present. So heavily calcified vessels, if you know your patient already has it, maybe CT is not the best test for that. And here's just an example. This was a patient, if you look at the short axis, axial slices, these are the femoral arteries. You see the femoral head there. And you can see that, I don't see the lumen. And, what do you call it, on the, what do we say about stenosis? So I think, the operator will said, both femoral arteries look occluded to me. And here it is, an MPR, of the vessel in its length. You can see the very dense, heavy calcification. And in this particular case, they were right. You can see by digital subtraction angiography, there's a region, I'm not sure it displays too well because of the brightness in the room, but there's a region where there's a chronic total occlusion. But could there have been some lumen and some flow? Absolutely. Just the degree of blooming can really compromise your image quality. What are some other limitations or risks with CT? We know that we're using iodinated contrast. And so, pick your patients appropriately who have reasonably healthy kidneys. The ones who are most at risk for contrast-induced nephropathy are those who are renally insufficient, especially those with GFRs less than 60. Diabetics, obviously, patients with poor low output. There's a risk of allergies. I think we're all very good at managing a lot of these possible risks. There is, of course, a radiation exposure. It can be a pretty good amount with a runoff. And so I would caution you, especially in your younger patients, especially females or those who may be pregnant or those who may be needing to do frequent repeated studies, that maybe CT is not the best choice. Choose a radiation-free technique such as MRI in that patient population. Now, with all of these limitations, that they are relative limitations. As we get newer scanners that are faster and able to help us possibly look through calcium and minimize the amount of blooming artifacts with all these newer generation scanners, these will become less and less and less of an issue. So, keep your eyes, and ears open for those developments. But they're especially with these newer generation CTs, a lot of what, I've put on the screen, may very soon be outdated, and I may be able to show you, images without any of these problems with the same resolution that you would have had in the cath lab. Let's move on to MRA. So MRA, we've already talked about how accurate it is similar to CT when it comes to diagnostic accuracy. Sure, images look a little bit different. There's expertise to be able to interpret these images. We usually acquire stations of data, but there are a lot of strengths of CT. MRI. These include no radiation, no use of iodinated contrast. Again, very high spatial resolutions and a 3D technique. Options to have non-contrast images of the vasculature that are produced without the use of any contrast can only be done with MRI. And so I will show you some of those. So, when it comes down to assessing difficult vessels or vessels where your patient, you need to know some anatomy, for whatever reason you can't give iodinated contrast or maybe even gadolinium contrast, we have techniques where without contrast we can look at the lumen. You can do functional imaging with that, and there's a lot to be learned about that. And of course other techniques where we can actually watch the flow of blood go through the arterial system and into the downstream organ and seeing perfusion of organs and things like that. Again, a lot of stuff that is actively being researched and looked at. So here's a great example of a strength of MRI and a limitation of CT. So this is a patient who's a diabetic. We know they frequently have heavily calcified vessels. You got the CT, and if you were the interpreter, you're going to have a bad day. Because nobody likes to give a report that, oh, I couldn't see this, and I couldn't see that, and I couldn't see this, and I recommend another test, right? And that's literally what you would have said if I showed you the images on the left. The below the knee vessels were very, very heavily calcified. It is guesswork to try to guess what's going on in the lumen. And maybe some of you would have seen the level of calcification, and just like that femoral artery I showed you previously, would have said, this vessel is occluded or there's major blockages. Well, look at the MRA, there are portions of very heavily calcified segments which have a non-obstructive lumen, and then of course there's areas that have focal disease as well. So, because with MRA, the MRI picture is produced by protons. You stimulate the protons. Calcium is calcium, really does not even contribute to the image. So calcium is not a limitation again for MRI. You can create a beautiful luminogram in very heavily calcified vessels. Oftentimes, in those patients who have chronic limb ischemia, these patients have a lot of inflammation. Whenever there's a lot of inflammation, for the sake of it, the extravascular space, extracellular space is expanded. Both gadolinium and iodine will very quickly go from the arterial system into the venous system. And it's not unusual that when we image with CT and sometimes with MRI, that in a patient who has critical limb ischemia or chronic limb ischemia, that you will have a lot of venous contamination in those vessels below the knee, just like in this picture, because of because of the fast movement of contrast from the arterial system into the venous system. Now you can imagine what a nightmare this is to try to figure out what's artery and vein. And oftentimes these vessels run very, very close to together, and you can easily mistake one for the other. So, what do we do in this circumstance? So if this was an MRI that had a lot of venous contamination, very hard to figure out what's going on. These are where I would mention to you we have techniques such as time-of-flight imaging, which are completely just based on flow, non-contrast techniques where we can see the lumen. And it can create a study, and at least you can go from a completely uninterpretable study on the left to a reasonably good idea what's going on an image on the right. One of the newer techniques that we are now using is something called the KISS, question interval single shot. These are, again, not to get into the physics of it, just to understand that these are non-contrast techniques. No gadolinium needed, no iodine needed, no nothing needed. Just push the patient in the scanner. You have 3 sets of images here. You have a CT scan in the middle. You can see the heavily calcified vessel. This is the image created on the left is your KISS MRA images. You can see the entire luminogram without giving any contrast. And I hope you can see that area that was heavily calcified by the MRA technique, it looks like the vessel is occluded within a region there, above the knee where you don't see any flow at all. And sure enough, when you look at the invasive gold standard, you can see that very tight, long lesion starting from the SFAs all the way to the popliteals. So, point being, benefit of MRI is if we get into trouble with the contrast techniques, we have some backups built in with these non-contrast imaging modalities. And this KISS technique was again shown to be actually, in this particular study, very accurate compared to the gold standard. I'm going to skip over this because I don't think it's relevant. In patients who have dissections, we have other tricks. This is just showing you the functional ability with MRI, where we can actually see the flow of blood, with phase contrast. We can actually see the timing of flow with our time-resolved MRI. And if we actually wanted to create a cinium of a vessel, we can do that as well. All right, what are some negatives? So it seems like right now we should be getting MRIs on everyone, right? So what are some limitations? Limitations are metal. So where this is a strength for CT, this is a major downfall for MRI. With that metal, you have a complete, the MRI scanners, as you've seen, do not like metal. And whenever you have metal, you'll have this signal void. And wherever you can see in these, where you have these arrows, it looks like there's a stenosis there or an obstructive lesion there. Actually, that's not the case. This was an area which had a stent present, and you're just unable to, visualize that lumen and really have no idea what's going on, other than the fact that you can say, yes, I see contrast distal to that stent. So probably it's patent, but I have no idea about the degree of stenosis there. Other limitations, its spatial resolution is a little bit worse than CT. So, now smaller vessels may be a little bit more difficult. Because we don't see calcium, you may not also see bony landmarks, and that may be important for planning procedures. And then the length of the study, as we discussed, can be issue for a patient who may be claustrophobic or uncooperative, or who's in pain from lying, because his hip hurts, or all the other stories that we hear. Other limitations, again, the technique of MRI is also rapidly advancing, and the scanners are also rapidly advancing. So a lot of this is relative and may depend on the institution you're at. But in general, patients who have a lot of metal devices, there are some metal devices that we should just not be scanning. And then there's the cardiac implantable electronic devices that more and more we're feeling more and more comfortable with, and we're doing regularly. Gadolinium, that's an interesting issue, and a lot has been moving in that sphere as well. Before, I used to show a slide where this was GFRs less than 30 was contraindicated. But now more and more data is showing that if you're using group 2 GBCAs in patients less than GFRs less than 30, use group 2 GBCAs in patients who are GFRs less than 30, because there has been very, very, very low incidence or any very low reports of the development of nephrogenic systemic fibrosis. So it's important to know what kind of gadolinium-based agent is being used by the MRI lab that you are referring to. Know that in our labs we solely use the group 2 agents. But in the past that this was a limitation, no longer. So I would just say that if you have a person with very markedly depressed GFR, make sure they're using the correct GBCA agents. Sure, can you have allergic reactions? Yes, we've seen those, and caution with pregnancy. So we have a special group of population. Sometimes you have this population, they're not on dialysis yet. So if once they're on dialysis, you can use iodine. But their GFRs are less than 30, And now we have, what do we do for these patients? We have, as I said, an option to use the group 2 GBCAs, but there's also a very good vascular agent called Ferumoxytol. This is it's an iron agent. It demonstrates paramagnetic properties and has been shown to create beautiful images. That's what you're seeing here on the right. You can really see the vasculature in great detail. And this is just another option for us to use. When you refer a patient to us, we'll use our best judgment in deciding between this or a GBCA. All right, so time is getting short. When should you consider CTA? If you need a fast study, if your patient would tolerate a faster study, if you need higher spatial resolution, if you need stent evaluation, if you need soft tissue and bone landmarks, if you have a lot of metal in the patient, when should you consider some strengths of MRA? We talked about, of course, the contrast MRA, but we have the non-contrast techniques. You really have no issues with calcium whatsoever. It's a less nephrotoxic agent, I would say. It's radiation-free, and it's great for repeat imaging because there's no radiation. And they all provide excellent anatomical assessment. So if I were to give you advice on what to choose, you have to know your local availability and expertise available. Know your patient, the test characteristics, its risks, and any contraindications. But just an idea, maybe, to help you. CTA for those who are critically ill, less cooperative, more claustrophobic. If you need stent analysis, maybe for patients who are on dialysis, smaller vessels, implantable metal devices. Consider MRA if you have younger patients, repeated exams, heavily calcified vessels, those who are diabetics because or renally insufficient because they're going to have a lot of calcium, may have iodine allergies, may need to use the Ferumoxytol, or if you're now getting into the function and flow kind of considerations as well. So just my take-home points, I'll leave them on the screen. I think I've really said the same thing over and over again, so I won't repeat it other than just to leave it on the screen. Be happy to answer any questions.